depending on how you define well-being, then obviously that will have implications for how you measure it. But what we do know is that there's variation between countries and within countries. We've got these, David Cameron in the UK is very keen on well-being measurement, and we've just had the latest measurement of these three. You can see three different measures there: happiness, life being worthwhile, and life satisfaction. And you can see actually there are quite good levels across the UK, but there's a significant minority whose well-being isn't so good. The different constituents of well-being are quite important, and when we think about these four constituents that Martin Seligman identified, the first one is pleasure, and obviously that's important. But engagement, so engagement both in relationships, work, a range of activities, but also meaning and purpose are very important. And those middle two, engagement and meaning, certainly are more kind of sort of consistent, I guess, with something like with Greek philosophy. Aristotle talked about the good life, so it's more than just pleasure. And then you've got this fourth one that Martin Seligman recently added on achievement, and achievement in a broad sense. And the maximum well-being occurs from not just focusing on one particular constituent, but actually trying to get a bit of a balance. The impact of mental health and well-being I was highlighting in the introduction, but it's more than just the absence of mental disorder. And because of the broad range of impacts, it's really integral to any promotion activity that we're doing. It's also very important in preventing mental disorder. And the health impacts, I put this slide earlier, but really the health impacts of improved mental health and mental well-being are across both mental health, physical health, and healthcare utilisation. But as I said earlier, across a broad range of areas outside health. I mean, if we're thinking about children and adolescents, we know that if happy kids are much more likely to study well, they're much less likely to get into trouble, and actually a broad range of outcomes that you can see there. Those impacts actually have quite a significant economic effect. I think I've lost my mind. Thank you. Thank you. Oh, that's better, right? So yeah, they have quite a few economic impacts, and there's been less work done on that, but David will go into that. In terms of the relationship between mental well-being and mental disorder, sometimes these things do get a bit polarised. But what we know is that if you've got good well-being, it reduces your risk of mental disorder. If you've got mental disorder, you're much more likely to have lower well-being. And the single largest group with poor well-being are actually that group with mental disorder. So if we're looking at the mental disorder, we can see that there's going to be a similar level of impact as we see for mental well-being. I just wanted to highlight these figures from WHO, which give us a sense of the very large impact of mental disorder compared to, for instance, other areas which may be also focuses of health promotion. And you can see that actually the very significant proportion of overall disability-adjusted life years, which is one measure of burden. But even these estimates are very significant underestimates because they don't measure a large number of mental disorders. And the size of that impact is due for these three main reasons that I'll go into. The first is that most lifetime mental disorder arises by early adulthood. And that's several decades before associated physical illness. And we know also that similarly, well-being arises very early. And again, that's in distinction to physical illness. Secondly, there's a very broad range of impacts, and as I said, similar to mental well-being. If you look at the impacts of mental disorder during childhood and adolescence, those occur both in health, but also areas outside health, and again, a broad range of areas. And I wanted to highlight, this is a study we do a big survey every 7 years in the UK, which measures the levels of mental disorder both in children and adolescents, but also adults. And on the left-hand column there, you can see a range of health risk behaviours. And then the two middle columns are the most common mental disorders in childhood and adolescence. So you can see that for those range of health risk behaviours and adverse outcomes, there's a several-fold increased risk of health risk behaviours in children and adolescents with mental disorder. And those impacts don't just stop when the child and adolescent becomes an adult. They translate into a broad range of outcomes in adulthood. And similarly in adulthood, if you've got a mental disorder, it results in a broad range of outcomes. Smoking as an example, we can see that actually it's over 40% of adult tobacco consumption, both in the UK, the US and Australia, is by people with mental disorder. The reason for that is obviously you all know that tobacco is the largest single preventable cause of death. And often mental disorder is not even acknowledged in terms of intervention or outcomes. The impact of mental disorder on physical health is also very significant, and the red figures here are the average number of years of life lost with different mental disorders. And you can see that the size of years lost is quite extraordinary for all these different mental disorders. This has an economic impact in Europe. The cost of mental disorder is close to 800 billion euros each year. To the UK economy, similarly very large. And I just highlighted a crime figure there. The third reason for the impacts of mental disorder are the numbers of people affected. And it's over 30% of people in the European Union each year experience a mental disorder, equivalent to over 136 million. These are the different types of mental disorder for people who may not be so familiar, but this is just the adult psychiatric morbidity survey, just highlighting the levels, and you can just get a sense that this is actually quite a heterogeneous group. Some people will never see a psychiatrist, others will see would see a lot of psychiatry for their treatment. The risk factors for mental disorder and protective factors for well-being, very important in a public health approach, because what we'd ideally like to do is to think about upstream how we promote well-being across populations and how we prevent people becoming unwell in the first place. And what's important to appreciate is that actually different organisations, government departments have roles in different risk factors and protective factors, and this highlights the importance of coordination. I've highlighted a broad range of protective factors for well-being here, and as you can see, it's quite broad and fits into different policy areas. But really just wanted to focus, particularly at the bottom there, on meaning, purpose, spirituality, and culture. And culture has a huge opportunity to actually promote well-being through values, and I know Brian's very interested in, for instance, meditation, mindfulness, and some of those protective factors can be very much embraced and supported through culture. The risk factors for mental disorder follow a similar profile to risk factors for other disease. Certainly during pregnancy, abuse of substances and tobacco use is associated with increased risk of mental disorder. But socioeconomic inequality is also very important. So a threefold higher rate of mental disorder in children and adolescents from lowest household income group compared to top. Parental factors are very important, parental mental health, but also parenting has a huge impact on the risk of mental disorder. And similarly, child factors, I just wanted to highlight, I've got the third one there, screen time. Was an announcement today by Public Health England about something that they're doing, which is giving parents information about the impacts of too much screen time. In the UK, it's an average 6 hours a day is spent on the screen by children and adolescents outside school time. So you can see that that's displacing a lot of other activities which would be otherwise promoting well-being, preventing mental disorder. Most importantly in childhood and adolescence, childhood adversity has probably the largest single impact on risk of mental disorder. And you can see here in terms of the second bullet that sexual abuse in childhood is associated with, well, 15-fold increased risk of probable psychosis, But it's not just the more severe end, it's across a range of disorders. And simply we don't have the information on well-being, but we can be pretty sure that there's going to be a big impact on well-being too. The impact of risk factors in adulthood is generally less, and you can see that the size of the impact is lower, but again is very much reflecting risk factors outside health across a broad range of the environment. It's not just the size of the impact of risk factors, but it's the proportion of the population affected by those risk factors. And I've just highlighted startling figures from the UK, which show the proportion of children and adolescents experiencing abuse, for instance. And therefore, this can be particularly important in the case of the UK. It's our social services who then would have a duty to intervene to protect. But I think more generally, to a public health level, to highlight this issue, to support parenting, to prevent abuse, and a range of other interventions are very important. Inequality underpins a broad range of risk factors for mental disorder and poor well-being. And so actually it's an important area to address to prevent mental disorder and to promote well-being. But also mental disorder then results in a broad range of further inequalities that we can do further prevention activity on. Really what I'm saying here is that there is a great opportunity to promote mental well-being and prevent a large proportion of mental disorder through these upstream approaches. If we can look at the various risk factors and then do something about those risk factors, and promote protective factors, we're in a great position to actually reduce this extraordinary burden and cost of mental disorder, but also make society a much happier, well-being orientated place. And such a sort of twin track approach is reflected in the UK's mental health strategy. It's important that any interventions or strategy recognise that certain groups have much higher risks of both mental disorder and poor well-being, and that such groups actually proportionately benefit from any interventions that are going on. And this has been reflected in a number of current discussions, both at the UN around what happens post-2015. And we know it's possible to estimate the numbers of people from those high-risk groups at a locality, regional or national level. And I'm just highlighting, for an example, just a number of different high-risk groups in the UK, but they can be obviously, they'll be relevant to, and they'll be different in different countries and cultures. And you can see the several-fold increased risk of mental disorder and poor well-being in these groups of children. And similarly in adult groups, certain groups have much higher rates of mental disorder, several-fold. I've just highlighted long-term physical conditions there. If you've got 2 or more long-term physical conditions, you're at a 7-fold increased risk of depression. And so that has implications in terms of, well, if we know that, then we should be targeting this group, both for treatment but also upstream promotion, prevention, because we know we can actually reduce the translation of that higher risk into illness. In terms of interventions to promote well-being and prevent mental disorder, there's an excellent evidence base, and that's been highlighted consistently, certainly in the UK, in the last 2 mental health strategies. And I've just highlighted just the level of evidence base for a range of interventions. A is the highest level of evidence. We've got randomised controlled trials coming out of your ears. B is we've got a couple of randomised controlled trials, and you can see that as you go down the list, the evidence base becomes less strong, but often it's reflecting research priorities, research investment. In terms of mental health promotion, what's helpful to look at or define in terms of interventions is interventions at primary, secondary and tertiary levels. And primary, where we're promoting protective factors for mental well-being across populations. Secondary is where we're targeting particular groups at higher risk of poor well-being, and tertiary for people with existing health problems to promote recovery. And one of the things in the UK, so I've been involved in a piece of work where we've looked across the life course to promote well-being in this way. And if we're starting well, so looking at parental mental health, we've got really excellent evidence base both to support parental mental health and physical health, parenting schools, but also support the early development of the child in terms of their well-being. And similarly, we've got very good evidence base in terms of developing well, so mainly school-based interventions, which can also prevent mental disorder from happening and result in a broad range of impacts, which kind of mirror the impacts that I highlighted earlier. School-based mental health promotion, particularly, you can see the level of evidence base is excellent, and particularly long-term, whole-school approaches involving teacher training and parental participation are associated with increased effectiveness. This programme in the States, involving over 250,000 students in its evaluation, is just an example and shows that there's reductions in both mental disorder, but also improved social and emotional skills, attitudes about self, and of course at the bottom there, improved academic performance on top, which again reflects that your well-being, if you're feeling happier, you're able to study and do better at school. In terms of living well, it's a broad range of interventions, and you can see that the evidence base is less strong here, but still very impressive, and really kind of mirrors a broad range of different organisations, different sectors across the community. And you can see that all of these are important in promoting well-being, and there may be different kind of aspects of this going on in any particular community, but also there'll be opportunities to actually engage, invest, promote particular types and particular communities. So great opportunities. Engaging well, I've used as a term, but really to support connection between people. So we know that social capital is very important for well-being, and that certain interventions can promote that connection between people, which promotes that social well-being. And again, there are a range of interventions. You can see that the level of evidence isn't so strong. Working well in the workplace, we spend a lot of our working day in the workplace. There are particular interventions that can promote our well-being there, reduce stress. I know there have been lots of sessions going on about workplace health promotion. But if we're looking at mental health promotion, stress reduction, that's very important. And also if we're thinking around targeted approaches, for instance, to people recovering from mental disorder, that's very helpful to actually reducing their time in hospital. Ageing well, a broad range of interventions to promote the well-being of older people. And again, you can see that the evidence base for those interventions is, again, very high. I've just put here at the bottom that promotion interventions are great, and they can also, on top of promoting well-being, mean that people are at much lower risk of developing mental disorder. But if we come to a way of looking at prevention, what I've tried to do here is to frame it again at a similar primary, secondary and tertiary level. So when we're looking at primary prevention, we're addressing upstream risk factors. Some of those risk factors I highlighted earlier, such as abuse, for instance. We know that certain groups I showed are a much higher level of disorder, so they need a more targeted approach. But we can then do a secondary prevention, so at the earliest stage of a disorder we can recognise it early, and that early intervention is associated with a broad range of benefits. And because I also highlighted this half of lifetime mental illness has started by the age of 14, 3/4 by the mid-20s, if we can offer people support at that earlier stage, we know that actually their outcomes are going to be much better. And then tertiary prevention is basically targeting people with established mental disorder to promote recovery. And then these various prevention interventions, and again you can see the level of evidence for them, but I've highlighted both prevention, mental disorder and dementia, but also health risk behaviours, inequality, discrimination, stigma, suicide, violence and abuse. Just wanted to highlight school-based violence prevention programmes. Violence and abuse we know are important risk factors for mental disorder and poor well-being. There are very effective interventions to address that, and that's again outside the health system, usually in schools, and very effective programmes to both prevent violence in school, prevent sexual abuse, bullying, but also of course to intervene early if we know it's there. Prevention of health risk behaviour, again good evidence around school-based programmes, but we know that actually health risk behaviour arises pretty early in the life course, probably at a similar time to when mental disorder arises, and so we can prevent both health risk behaviour and associated mental disorder. And really this kind of brings me to the point around the importance of integrating mental health into programs that are addressing health risk behaviour that often tend to be separate. You're addressing smoking, alcohol, drug misuse, sort of unhealthy eating, but actually if we can mainstream and integrate mental health and well-being into that, I think we can really enhance outcomes of interventions. Early recognition of mental disorder associated, as I said earlier, with much better outcomes, and essentially there's a great opportunity to prevent a large proportion of mental disorder if we can intervene early, from particularly one study of Kim Cohen at the bottom there. The economic impacts of interventions, certainly this was highlighted in the London School of Economics work for the UK's mental health strategy, and the savings are, even in the short term, a large proportion accrue in areas outside health, and there's a cost of not providing such interventions. The figures in red here are the net savings for each pound spent on a range of prevention interventions. So you can see that actually, if you were playing the stock market in any country, and these were the savings that you were getting for each pound, euro, or whatever that you were spending, you'd be going straight for this. And similarly, for prevention of conduct disorder through social emotional learning programs, for each pound you spend, you get net savings of £84. And so there's actually a very important economic issue surrounding this, both in terms of economic recovery, but also economic protection and economic health of a region or a nation. The impacts of interventions, they're very broad, and really the slides that I highlighted earlier are just emphasising that both the mental health, mental disorder, and addressing those areas result in a broad range of impacts both within health and outside health. And actually the interventions are coming from a broad range of sectors, both primary and secondary care, but public health, local government, and you can see that it's very broad, and the need actually to have mental health integrated into each of these organisations, but also to facilitate cross-sector coordination between those, so each of them are working in a joined-up, coordinated way. And I've just given some examples of the levels that different organisations can work at. So again, different organisations are working at different levels. They're not all doing the same thing and very much complementing each other. We can assess what different organisations are doing, where they fit together, through a kind of needs analysis or an assessment of what different work is going on at a locality level or at a regional level. And this is very helpful in terms of highlighting to a broad range of stakeholders that actually what they might not be realising that they are promoting well-being and preventing mental disorder, but is also helpful to embed some of this mainstream and integration of mental health. The intervention gap is very significant. Very briefly, that it's only 10% of people with mental disorder in the European Union get any treatment. They're also much less likely to get help for their much higher levels of health risk behaviour and poor physical health. It's even less in low and middle income countries. But in terms of mental health promotion, even in the UK, it's less than 0.1% of the mental health budget. And there's a lack of integration of mental health into health promotion, public health, despite the broad range of impacts I've highlighted. And that gap actually results in a huge level of suffering, impacts and costs. And those impacts continue across the life course. However, we can actually estimate both the size, the impact and the cost of such a gap, and that's very helpful in informing policymakers at local, regional and national levels. And just to say, a piece of work that I've done, really sort of highlighting estimation of both the level of risk factors and protective factors, numbers from high-risk groups, and the proportion receiving different levels of intervention, which can then enable us to sort of get a good idea about what's going on at the moment in terms of impact, what is of those interventions, including economic savings, but also the impact of that gap. The transparency of provision of such interventions is helpful. It informs strategic planning and potentially investment. So basically the key message is mental health, a broad range of impacts, a central part of health promotion. Cost-effective interventions exist, both to promote mental health, prevent mental disorder. But there's virtual absence of implementation, which results in significant impacts and costs. We can estimate the size, impact and cost of that gap, and that's particularly helpful in increasing awareness across a broad range of stakeholders, and that public mental health training for promotion professionals is important because it enhances a broad range of outcomes associated with promotion. A few references there, my email contact, very happy to take questions maybe after we've each given a presentation. We'll have a bit of time for discussion at the end. So I'd just like then to maybe go straight into David McDade's presentation. So David is an economist at the London School of Economics and done a huge amount of work on mental health promotion, mental disorder prevention in terms of the economics and the costs. So over to you, David.
Thank you. I think we should give Jonathan a round of applause.